Today I will be discussing Brian Mulligan's mobilization with movement treatment technique to regain dorsiflexion range of motion. Objectives of this presentation are as follows. I will first discuss what the Mulligan concept is. I will highlight current research behind the Mulligan concept for increasing dorsiflexion, while offering suggestions for future research. I will then show a demonstration of me performing a mobilization with movement of the talar crural joint, then we will together as a class perform the technique. Brian Mulligan believes that minor positional faults occur following an injury resulting in movement restrictions and/or pain. When a correctional mobilization is performed, pain-free function is restored and several repetitions will begin to bring lasting improvements. A mobilization with movement is a concurrent application of an accessory mobilization with active physiological movement, meaning that the PT provides manual overpressure to the patient's talar crural joint while the patient is asked to actively dorsiflex their foot. This technique can be performed in weight-bearing and non-weight-bearing. All the patients in the 3 studies showed improvements in their dorsiflexion range of motion after a single mobilization with movement treatment. All 3 studies reported a p-value less than 0.05, indicating that there is strong evidence that there is in fact a difference between the subjects receiving the Mulligan treatment compared to the control group. While a p-value informs readers whether an effect exists, the p-value does not reveal the size of that effect. The studies therefore also use effect size. Effect size is a way to quantify the size of the difference between the treatment group and the control group. Effect size is usually the raw mean difference between the treatment group and the control group. Since the effect size encompasses 0, you can conclude that the 2 populations are not significantly different, meaning that there is a probability that mobilization with movement treatment could have little or no effect. There is a discrepancy between the p-value and effect size because the p-value is dependent on the sample size, while the effect size emphasizes the significance of the effect rather than the sample size. The sample size of these 3 studies either consisted of 16 patients or 23 patients. Despite the improvement in dorsiflexion in the studies discussed, Mulligan treatments created small to moderate effect sizes. It is no surprise that a single Mulligan treatment resulted in small effect sizes because the full treatment effects of this intervention are typically seen over several sessions. Studies with the single treatment sessions combined with a low number of subjects thereby limits the treatment effects seen. Future studies should include patient assessment and follow-up after a series of mobilization with movement treatment sessions. Research should also explore the influence of this treatment on patient functioning during gait, postural control, and other movement tasks. The current studies available on this subject are of level 2 evidence, meaning that they are designed cohort studies or case control studies. However, to really investigate the effect of using the Mulligan concept as a treatment, randomized control trials should be performed consisting of longer treatment durations, longer patient follow-up periods, consist of larger sample sizes, and include self-reported measures of function. These are my references that I used, and here's my video demonstration. So the belt is wrapped around my waist, also around the patient's distal tip fib. There's a towel placed for comfort. As the patient is lunging forward, they are dorsiflexing their foot, and the belt is providing an anterior force to the distal tip fib while I am manually providing a posterior force to the talus. Before I would do this, I would assess the patient's dorsiflexion range of motion and pain level. I would perform this technique for 6 to 10 repetitions as long as they are not experiencing any pain during this treatment session. Then I would reassess the patient's range of motion to see if it increased and to see if their overall pain level decreased. In my opinion, the Mulligan treatment is effective at increasing dorsiflexion range of motion. All the subjects in the studies did have a positive outcome and did have an improvement in dorsiflexion range of motion. However, there is definitely a need for future research on this subject, considering there is limited studies out there,